Good afternoon and welcome to today's webinar, Preventing Communicable Disease Through Vaccination Laws, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. Please feel free to submit questions at any time by using the Q&A tab on the right-hand side of your screen. We strongly encourage attendee participation in our webinars and would love to hear some of the thoughts and questions that you have. All you need to do to submit a question is click on the Q&A tab, select all panelists from the drop-down menu, and submit your question. If you do not see the Q&A tab available, click on the button with the three dots highlighted in the picture. Your moderator for today's webinar is Chelsea Gullinson. Chelsea is a staff attorney at the Network for Public Health Law's Western Region Office and a research scholar with the Center for Public Health Law and Policy at Arizona State University. Her work focuses on public health emergencies, the opioid crisis, reproductive health, and technology. Chelsea will be leading us through the rest of today's webinar. So Chelsea, over to you.
Hi, everyone, and thank you, Charles. Thank you, everyone, for joining us today for our webinar on preventing communicable disease through vaccination laws. Recent declining vaccination rates across the United States and outbreaks of measles and mumps cause concern and reinforce the need for a well-vaccinated population. Our panelists today will discuss vaccination mandates and efforts at the state, college, and local levels. I'd like to go ahead and introduce our panelists, each of whom will speak for about 20 minutes, and then we'll have a really nice 30 minutes at the end for Q&A. So our first panelist, Leila Barraza, is a consultant for the Network for Public Health Law in the Western Region Office and an assistant professor in the Division of Community, Environment, and Policy in the Mel and Eden Zuckerman College of Public Health at the University of Arizona. Her research interests include studying the impact of laws and regulations on population health, both nationally and globally. Through her work with the Western Region Office at the Network, she has addressed over 100 technical assistance requests on various public health law issues. Corey Redden serves as a Biodefense Preparedness and Response Administrator for the Pinal County Public Health Services District in Arizona. She is responsible for both the CDC Public Health Emergency Preparedness Cooperative Agreement and CDC Cities Readiness Initiative Grant for the Health District. Corey also serves as a Medical Countermeasures Coordinator for the county. She has served in command roles for public health emergency outbreak responses for measles, varicella, H1N1, Ebola, and sheltering operations during wildland fires. Nancy Barrera is a senior attorney with the California Department of Public Health, Office of Legal Services. She has extensive experience in public health and has advised various public health programs, including tobacco control, chronic diseases, vital records, injury control, family health programs, healthcare quality, health equity, and civil rights. Currently, she advises the communicable diseases and emergency preparedness programs on important public health legal issues. Again, thank you all for joining us. I am now going to pass on the presentation to Leila Barraza.
Thank you, Chelsea. I'm going to begin now with the webinar, and I'm going to focus on vaccine requirements at the university level. Oftentimes when you hear about vaccine laws and vaccine requirements, it's referring to requirements for children when they enter kindergarten and the vaccines that are required for them to enter school. But in this case, the Western region of the Network for Public Health Law wanted to focus on the requirements at the university level, at higher education level, just to examine what requirements really existed and what was out there among different universities. Okay, so we had a few objectives. We wanted to explore the various approaches universities in the Western region had for requiring and recommending immunization. We wanted to examine university responses to large-scale outbreaks of vaccine-preventable disease. And we wanted to analyze interactions between state law and university policy on post-secondary immunization requirements and recommendations. So as of January 2019, so this is some recent updating we've done for this chart, looking at universities in the Western region. And if you look on the Network for Public Health website, you'll see a map of the different regions of our network, and the Western region comprises 11 of our Western states in the U.S. So we took those states that are covered by the Western region and looked at universities within the region, universities specifically that had over 1,000 students. So we took the largest university, one public, one private, with over 1,000 students, 4-year in-person universities. And in some cases, if there wasn't an in-person private university that had over 1,000 students, they unfortunately were not included. So you'll see some states like Nevada and New Mexico that are missing a private university, and that is why. But the states here show or list the universities that we identified, public and private, and the requirements or recommendations for vaccination for students. So the teal green is the required, and that lighter green is the recommendations. And you can see they really vary among universities. So while state law really regulates and mandates which vaccines a student must have to enter kindergarten and grades in elementary and middle school, universities are done at a different level. They're regulated at their own level, meaning that state law usually does not regulate the university requirements recommended for vaccination. So that's why you see the variation here within the different states and the different universities. We've also listed here the different vaccination exemptions that are allowed for the universities. There we go. And the reason we wanted to do this project was because there have been quite a few vaccine-preventable infectious disease outbreaks among higher education institutions. So we created this map here. So between 2014 and 2018, we outlined different outbreaks relating to mumps and meningitis. So there's been quite a few mumps outbreaks on university campuses. And seeing this and seeing the spread of these outbreaks really inspired us to do this project and look at the varying policies among the universities. We also went specifically by vaccine, looking at the different vaccines and how many universities in the Western region that we found required them. And you can see the most common requirement was the MMR, and very few actually recommended some of the other vaccines, like, not many recommended pneumonia or polio, but many required MMR, a few required the meningitis, a few required varicella, but there was quite a variance in the requirements and recommendations. This chart shows the exact number that the different universities require, the different number of vaccines, so public versus private. So looking, for example, at the University of Washington, the requirements, they had 2 required vaccines, where the University of New Mexico had 0 required vaccines. And University of Southern California had 3 required vaccines, but quite a few recommendations. So there was quite variance here to show that it's not the same, it's not universal, and different universities really require different vaccinations. We have started to expand this project to look at universities across the country. And in our initial samplings, we have not completed all of the work to look at the whole country. We've just established the Western region thus far. But in our initial review of the requirements across the country at public and private universities, again looking at universities that have over 1,000 in-person students, we found some interesting patterns among even universities outside of the Western region. So far, we've found the most immunization requirements at these universities, public universities including University of Massachusetts, UCLA, Utah State, the private universities, Johns Hopkins, Baylor, and the least immunization requirements at Texas A&M, CU Boulder, University of New Mexico, Wilmington University, and Hawaii Pacific University as the private ones with the least amount. And as mentioned, University of New Mexico University of New Mexico has no requirements, and CU Boulder actually also has a few requirements, but not very many. So those are the least requirements, with Wilmington also not having any required, just recommendations. And Utah State, I mentioned, requires proof of immunizations for measles, mumps, rubella, polio, chickenpox, tetanus, diphtheria, and pertussis. These were actually done and added as a policy based on outbreaks of vaccine-preventable illnesses. So the university released a statement that said the nationwide rate of vaccine-preventable illnesses has been increasing steadily for some time, and the area that serves as the home of Utah State University has experienced similar trends, and for this reason, they changed their policy and required it to match that of what would be required for entry into the grade schools, middle schools, junior highs, and high schools within the state. So instead of having different requirements for university levels, they decided to mimic that of the local requirements to create universal protection for those in the community. And here's the slide I was looking for earlier, but University of New Mexico, no vaccination requirements, and it ranks among the lowest of what we've seen so far. There are categories, they do provide categories of recommendations, but no actual requirements. As I mentioned, the universities requirements are done separately, usually from state law. However, there are some states that have policies or laws in place that do influence the decision of the universities and how their requirements are put into place or what the requirements look like. Two examples of that are Nevada and Texas. So in Nevada, Nevada Administrative Code requires that any student under the age of 23 must provide proof of immunity to bacterial meningitis, and that's if they wish to reside in on-campus housing as a freshman. And in Texas, Texas directed the Texas Higher Education Coordinating Board to require that all entering students be vaccinated against bacterial meningitis if they are under the age of 22. So these are examples of where state law has influenced the requirements at the university level for vaccinations, but this is really rare. This is not the norm. In most states, the universities have their say in what requirements they recommend or require for entrance to the university. Here we looked at universities with the largest mumps outbreak since 2014. This chart kind of illustrates what that map showed at the beginning of this presentation. So looking at the specific requirements by vaccine, looking at the University of Iowa, University of Illinois, Urbana-Champaign, Harvard, Syracuse, Ohio State, all of these universities experienced mumps outbreaks. And so we charted here the specific vaccines required for those universities. Interestingly, those universities require MMR. If you look at the bottom chart, even though there was a mumps outbreak. So they did require it for entrance, but they did provide exemptions. In the chart at the top, you can see the changes that happened at pre-outbreak and post-outbreak. So the Ohio State University did not actually require the MMR pre-outbreak, and then post-outbreak, they added a requirement for the vaccine before matriculation into the university. A couple of universities had some interesting responses to outbreaks on their campus, specifically looking at Illinois, Iowa, and Ohio State. Illinois held a vaccination campaign for MMR vaccines in 2015 after an outbreak occurred there, and they recommended students receive a third dose of MMR during the outbreak, and we've seen that in other university settings as well when there has been a mumps outbreak. Iowa held a vaccination campaign in which 4,700 MMR vaccines were administered, and it recommended students receive a third dose of MMR during the outbreak. Ohio State, as I mentioned, began requiring students to actually provide proof of the MMR vaccination in fall 2014, and that was a semester after their outbreak occurred. They now require 7 vaccinations if you live on campus, 2 more than any other school that we've looked at so far. Illinois and Massachusetts. Illinois Administrative Code requires all students to provide proof of 2 doses of MMR, and that became effective in fall 2016, and that was a semester after the conclusion of an outbreak. And Massachusetts required all newly admitted full and part-time students to provide proof of 2 doses of MMR vaccine, and that was effective fall 2016, also the semester after the conclusion of their outbreak. One interesting difference we found in some of the universities when looking at their vaccination policies was when actual proof of vaccination was required. So some universities required vaccinations to be proven before students actually entered campus, and some students or some schools required it after they'd actually been on campus and were entering their 2nd semester. So an example of this was Illinois, where the MMR immunization requirements were not enforced until new students attempted to register for classes in their 2nd semester. So this means that students may be on campus even if they haven't proven vaccination, or would be on campus even if they had not proven vaccination status, if they had not submitted their forms prior to entering the campus. And compare this with Syracuse, where the proof of the MMR immunization had to be submitted and approved before the student could arrive on campus. And students who did not have proof of the MMR immunization on file were not permitted to even register for their 1st semester classes. So we found these 2 different scenarios really could create a problematic situation for vaccine-preventable diseases, because you would have students on campus that did not have proof on file of their vaccination status until that 2nd semester. Overall, we found quite a few inconsistencies and shortcomings of immunization policies, and these inconsistencies and shortcomings could really increase the risk of vaccine-preventable disease outbreaks on university campuses. And states may implement minimum standards, but universities generally have the power to create their own policies in regards to recommendations and requirements for vaccination. Delayed implementation and various vaccine exceptions may present barriers to successful immunization policy. We saw the universities that allowed for many exemptions to their vaccine requirements, and this could create a university setting where there are many students that weren't fully vaccinated or had all of their required vaccinations. And that concludes really our look at the university policies. I think we have more work that we are continuing to do in this arena, and it's a really great topic and a new topic for us to research in an area that I think is interesting amongst all of these recent outbreaks we've seen across the country now, to really see these opportunities at university levels to look at their vaccine and requirements and recommendations, which haven't really been studied quite as much in the past as elementary and middle school requirements. I have some acknowledgments here for help with this presentation, and my email, if anyone is interested in following up, I'm happy to answer questions, and I know we will do questions at the end. I'd like to now pass it to Corey Redden.
Thank you, Leila. Again, my name is Corey Redden. I'm with Pinal County Public Health Services District in Arizona, and I'm going to talk about vaccine-preventable disease outbreaks that we've experienced. I want to provide all of you with a visual of the state of Arizona. There are 15 counties. Maricopa is the largest by population. Phoenix is its capital. Pima County is the next largest by population, where Tucson is the county seat. We are the county in between these two, so we are considered the largest rural county by population. 2010 census data has us listed with a 375,000 population, and we are approximately at 406,000 right now. So while we are not the largest county by landmass, our county is the size of Connecticut, or roughly the size of Connecticut, if that gives you a perspective into how large our county is and how large the state is. I would like to provide information on some of the significant vaccine-preventable outbreaks our county has experienced within the last decade. So the first is the 2010 varicella outbreak. So let me set the stage on this one. This occurred in a K-8 public school in November, right before Thanksgiving. This was 1 year after our 2009 H1N1 vaccination response. In July and August of 2010, we had completed back-to-school vaccination clinics in 12 schools throughout all areas of our county. We didn't have a huge turnout cumulatively, but we wanted to provide this convenience to our schools and parents. We utilized remaining H1N1 funding, and we also wanted to improve on some lessons learned from the H1N1 mass vaccination operations we conducted. So the first index case was on November 15th. There were 3 cases that week. Then the children go on Thanksgiving break and come back to school on November 29th. Boom, here is your second wave. These cases are coming into our surveillance system 1 to 2 days after diagnosis or via verbal reporting with the provider or school. Case number 1, 4, and 6. Number 6 is one of the 3 cases reported on December 2nd. They're all family members. They are all shown in yellow bars. So the index cases in this family. Their age ranges are from they're 13, 11, and 9 and span over 3 grades, 7th, 6th, and 4th grade. There were 2 students in 7th grade, 1 student in 6th grade, and 2 students in 4th grade, and 2 students in 1st grade. Out of these 11 cases, 5 of these cases were personal exemptions, no vaccination. 5 were 1-dose recipients, and 1 had a history of the disease, but they probably had a very low titer or antibody level. So we have 11 cases and 3 grades affected by December 4th. We assume there may be more cases at this point, so on December 7th, we decide that we need to activate a response. We initiate a call with the principal and superintendent and school nurse on the afternoon of December 7th. We wind up getting cases 12 and 13 reported to us in our system on the 8th. So it validates our decision to move forward with the alerting of the school and working on a plan to stop this outbreak. By the way, cases 12 and 13 are also in the 7th grade. So we have our conference call with the school officials. And they're concerned, but they still ask, don't we do chickenpox parties still? We provide the following disease risks associated with varicella and confirm that those chickenpox parties are probably a bad idea. This can be more fatal in adults and children. 1 in every 100,000 children will die, and 1 in every 5,000 adults will die. So this can gravely affect children with leukemia and neonates. If the mother is infected, she can pass this on to her newborn. That has up to a 30% mortality rate in the newborns. Overall, if the mom acquires varicella during her pregnancy, this can cause fetal demise, and we refer to that as congenital varicella syndrome. Additionally, once you've had varicella, you are more likely to develop shingles later on in your adult life. And varicella and shingles are both very highly infectious. When we mention all of this to the school officials, the seriousness of this outbreak becomes palpable. I also would like to share that with all of you that I had the horrible misfortune of acquiring chickenpox for a second time at age 26, likely from an exposure to shingles at the time. And yeah, adults can get sick. My liver enzymes were elevated. My resting heart rate was 130 beats a minute. My blood pressure was 80/60. I won't even mention the vanity one has at age 26 when you get this disease. But luckily, there is a vaccine for varicella. It was available starting in 1995. So here are the ages for dose 1 and dose 2. However, only 1 dose is required in Arizona, which provides 85.7% efficacy. 2 doses are recommended, offering up to 99.6% efficacy. This data is from a major study, but other studies showed 1 dose eliminates disease completely in 70 to 90% of exposures and is 95% effective against severe disease. However, we did have some of our cases that were only 1 dose recipients. So we are looking at high transmission of cases in the school population, so we want to ensure at this point we have two dose coverage as best as possible. We recap. Here's the gap in transmission, most likely due to Thanksgiving. We are in a second wave. We could get into a third with winter Christmas break starting at the end of the week. The school has a modified year-round schedule. So we're not going to take our chances, not a good idea, and we don't want this spreading during winter break now that we know we have an outbreak. But we got to act quickly before these children go on their break. So we want to get these children identified and vaccinated while we have them in school. The health department and the school officials agree to mass vaccinate right before the break on Thursday, December 9th. So our call is on the 7th. We're going in on the 9th. They also agreed to exclude exempt students utilizing our Arizona Revised Statute Title 15-873, which reads exemption, non-attendance during outbreak. So it's the afternoon of the 7th. It gives us 1 day to identify all the school population for 1 dose coverage and exemptions. The school nurse has to pull these records on everyone. The health department has to draft a letter that goes to the parents explaining everything and how imperative it is to complete this form if their children require vaccination. We also have to include a vaccine information statement with the letter if they are going to consent to vaccination, so they have that information. This letter also has to pass our legal, pass schools legal, and we get all of that done on the 7th and the 8th. We get all of these packets together on the morning of the 8th to go home with the children that afternoon. The school also conducted a notification call, and this is similar to like a reverse 911 call to notify all the parents. The students with consent arrive on December 9th for mass vaccination. Additionally, on the 7th and 8th, we're securing all our equipment, personnel, resources to go into the school on the 9th. Also, varicella vaccine is frozen, so it has to remain in compliance before and during administration. Luckily, at this time, it's 2010, and the CDC Vaccine for Children program was offered to all children 19 and under, regardless of insurance status. So all children are receiving this vaccine free, and we don't have to check for eligibility. This, of course, would be a different story today, definitely more complicated. So we have 487 students that were identified as having 1 dose of varicella. Excluding the current outbreak cases that were exempt prior, the school currently had 24 students with a personal exemption. They were all given the option to consent to vaccination or have their child return after the winter break, on a caveat as long as the outbreak was concluded by then. Most of them took the news well, but some stated, some stated that they would consent to vaccination, which was great. But there was one parent actually with a medical background that stated that they knew their rights and they knew their children couldn't be excluded. This prompted us to be ready for pushback, and we definitely did some information sharing with our law enforcement partners just to ensure that everything, all the peace was kept when we went into the school. But the parent wound up not showing up, and nor did their children. We also didn't leave out our faculty and staff immunity protection. We asked about pregnant breastfeeding staff and those with newborns. We asked if they needed to be excluded from working, and to have the pregnant moms check with their healthcare providers and keep their providers in the loop. There were only a few that were in this particular population, so actually all of them agreed that they would stay home. And in addition, other adults may not have received the vaccine, and some may have had varicella when they were younger or in their lifetime. So we definitely had to differentiate between these two. As a result, we didn't have any major issues with the adult population, but it was definitely good to check. We wound up creating 487 packets to take home, including the 24 exemptions in case they agreed to vaccination. So here are our final numbers. We wound up vaccinating 110 students. Out of the 24 exempt students, we vaccinated 12. We actually evaluated a little bit more than who we vaccinated. Some actually provided a second dose or proof and proof of that second dose upon arrival. Others had some identifying health issues that prohibited them from getting vaccinated. So we definitely just kept them informed and ensured that they were not going to be exposed. We had 20 county personnel during this mass vaccination operation. We set up our facility in 22 minutes, and we gave vaccine from entrance to exit. We got those students out within about an average of 2 minutes. So we were very swift after doing all of our back-to-school shots in the summer. We had definitely were very effective and efficient. So here's what the outbreak looks like from start to finish. We believe our vaccine intervention prevented further cases after December 6th. We think we prevented a third wave as a result. So let's move on to our 2015 measles outbreak. And this pretty much sums up what we think about the whole thing. This response took on a different look than our varicella outbreak, and this was definitely related to the Disneyland outbreak. Going over the severity of measles, it is highly contagious. It is airborne. Those who are unvaccinated or not immune will have a 90% chance of contracting it when exposed. Interesting, the virus can live in the air up to 2 hours after an infected individual is no longer in the room or immediate area. This has a 21-day incubation period. The indicative signs are high fever over 101 degrees, cough, runny nose, red, watery eyes, and that rash. Infectious 4 days prior to a rash, and you're infectious 4 days after the rash. So when the rash pops up, you've already exposed people for up to 4 days prior. Severe complications with this, 1 out of every 1,000 children will develop encephalitis, and that can lead to convulsions. It can leave the child deaf or mentally retarded. For every 1,000 children, 1 to 2 of them will die from measles. And again, we can prevent measles with vaccination. We have the MMR shot, measles, mumps, rubella. 2 doses of MMR during your lifetime offers the best protection, and this is the vaccine schedule. Populations that are unable to be vaccinated are those under 1 year of age, if they have a life-threatening allergic reaction to any of the vaccine components, or they're allergic to neomycin, an antibiotic. Pregnant women who have not been previously vaccinated, they have to wait till after they have their baby before getting vaccinated, and of course any immunocompromised individuals. So, as previously stated, our outbreak was a part of the nationwide outbreak affiliated with Disneyland. At this time, this was the case count at this time and the states that were linked. This definitely looked different after the outbreak concluded nationwide. In January 2015, our state resulted in having 7 cases. 2 were in Maricopa County, and then you had our 5 cases in our county. The dates are when the cases are getting announced in January. Our cases were from an unvaccinated family in our county, so let's look at the timeline. So here's your family, cases 1 through 4. They visit Disneyland between December 16th through the 20th. The index case gets sick, has a fever on January 1st, rash on the 2nd. Child goes to the doctor on the 2nd, Doctor suspects it could be measles but isn't too sure, and thought maybe it also could be scarlet fever, group strep A. Family does not consent to a blood draw to run tests. The case goes home. Index case exposes cases 2, 3, and 4. Cases 2 and 3 are siblings of case 1, and case 4 is the parent. So this is a divorced family. You've got one parent and 3 children at home. Cases 3 and 4 get sick with fever on January 7th and 8th and develop rash on January 10th and 11th. Case 2, a child also got sick with fever on the 7th, but stays with the other parent from January 7th through 11th. Since case 2 is sick with fever, the parent takes the child to a pediatric urgent care in the afternoon in Maricopa County, another county. They consent for testing, but the case is too difficult to get a blood sample on. This is Sunday the 11th. The parent takes the child back to the other parent that evening, and that other parent goes back to work the next day. This case, the child doesn't develop a rash until that night. So they did not have this rash while they visited the urgent care, but that night they have it. Case 4 is the parent that went to Disneyland and goes to the hospital in another county, Gila County, to the north of us. East of us, on January 14th. This county borders our county. This parent consents to a blood draw and also has case number 3 with them and consents to a blood draw as well. It's too late for case number 1, and case number 2 did not get blood drawn. It was the child was too difficult to get a blood sample on. So we've only got a couple of blood samples that we can confirm or, really confirm measles on. So this is January 16th. It's been over a week, and the kids have not been in school. The school nurse calls the family. The parent states they've been diagnosed with measles. The nurse immediately calls our health department. The hospital that parent went to never reported the suspect cases to the health department in Gila County, and we had to start piecing the parts together. In the interim, the other parent starts to get sick on the 18th. This parent was previously vaccinated, but only had 1 shot. Then develops a rash on the 22nd. Doing the math, this parent has been infectious since at least the 14th. So this is now case 5. This case worked while infectious, went to an all-day training session where there was a large portion of employees congregating in a closed room. This case went to several commercial businesses, a pharmacy, a post office, a convenience store, a grocery store, went everywhere. So we actually retrieved receipts from the businesses to ascertain time and place. These businesses had to post notices alerting the public. Measles can remain airborne for up to 2 hours in a building, and because we weren't sure exactly how long this case was in each establishment, we went back 30 minutes from time of receipt and calculated 2 hours after time of receipt. And we messaged out to everyone. We put up posters in the community areas throughout the county. This is a small mining community. We have a large copper mine in this area of our county. This community receives weekly print newspaper on Wednesdays. There is not a significant use of social media in this area. Word of mouth is the highest form of communication. Their TV news feeds come from Tucson and Phoenix, so we had to rely on primitive forms of messaging. And that's the reason for the posters. So we also used this as a visual to raise awareness. Prior to this outbreak, measles outbreaks were not as common, and not a lot of your newer doctors had seen this rash before. So this was a significant part of our response. We messaged out to providers to think measles until they could rule out. The same Arizona revised statute applied to the outbreak, but we didn't have to use it. This school that the family was in, they're the only family that have exemptions. Everybody else had 100% coverage rate. So that was good. We still messaged out, but that was good. We also looked at our vaccine status, and it was kind of low in January. We should be much higher in our MMR, and that's your red bar is our MMR vaccine. There we go. We did capture what the worst case scenario would be with our schools, and we were looking at a 4.9% exemption rate in our county, and we definitely had almost 20 schools that were above that, and we had one that was close to 17% exemption rate. So this could have been a perfect storm had that other school not had a good exemption, a good coverage rate, and that we had really not a lot of exposure outside of this area. So we kept up with our objectives. We're going to message, we're going to identify, we're going to test suspect cases, we're going to vaccinate as much as possible. We definitely used our clinics to our advantage and our WIC staff, linking clients to vaccine services. That was key. We also used our vaccine manufacturers to definitely do automated calls out and postcard mailings to children, to parents of children who are missing vaccine doses. So we were able to, after those next couple of months, really increase our vaccination coverage on MMR. So our timeline is we activated on the 23rd of January, and we kind of scared the NFL because the Super Bowl was coming to Maricopa County on February 1st, so they definitely wanted us to contain this outbreak. We concluded the first incubation period on the 13th of February, and then the second incubation period, that's usually when we will call off an outbreak if we haven't had any cases. So luckily we did not have any cases. We kept it at 5 in our county, kept it at 2 in Maricopa County, and had just a total of 7 cases in our state. But this is costly. We tracked our time and effort, our manpower, and all of the cost. And the cost of the outbreak was $86,000 for just really what was a brief time. And really nothing has changed because we thought maybe we would get better coverage rates and less exemption rates, but we don't. Our percent of vaccination exemptions has increased by 0.5%. And we have about the same amount of schools that are above that rate, and one that is close to 12% at this point. Just another couple. I know due to time constraints, really can't get into any other preventable disease outbreaks, but we did have one the following year, but it really was just concentrated to an ICE detention facility. But that heightens our awareness of the vulnerability that exists in our international populations that do not have adequate vaccination coverage. We have had some smaller outbreaks of mumps, and of course both in unvaccinated exempt children and in some adults with a waning antibody level. We are dealing with some of the hepatitis A outbreaks. Our county has not experienced the one with the homeless, involving homeless populations, but we have had some foodborne exposure. And I think that concludes my presentation, and I know we'll get to questions afterwards. And this is my contact information, so definitely feel free to reach out. And now I believe I will turn it over to Nancy.
Great, thank you, Corey. I'm going to talk about the immunization law in California, and just a brief disclaimer. This presentation is made for information purposes only and should not be construed as legal advice. I will be talking about or discussing the context that led to the enactment of California Senate Bill 277. Second, I will review the changes that SB 277 made to California law. And thirdly, I will discuss the legal challenges against SB 277. So before SB 277 went into effect, we had Assembly Bill 2109. It was passed by the legislature in 2012. It amended previous law, which only required that a letter or affidavit from a parent or guardian stating that the immunization is contrary to his or her beliefs be submitted to the school. Beginning January of 2014, AB 2109 further required a signed letter or affidavit documenting which required immunizations were given and which had not been given based on personal beliefs. It also required a completed form prescribed by the California Department of Public Health to include a signed statement from a healthcare provider that he or she provided the parent or guardian with information about the benefits and risks of immunization and the risks of communicable disease. And it also required a signed statement by the parent or guardian that he or she received the information from the healthcare provider. Taking a look at the percentage of kindergartners with PBEs, we can see that prior to the enactment of AB 2109, there was an increase in PBEs, and in 2014, when AB 2109 went into effect, we see a decline. Looking at the percentage of kindergartners with completed required vaccines, we see that prior to AB 2109, there was a decline, and in 2014, we start to see an uptick. And in particular, the MMR, which is in green, we see that it is still below the 95% threshold level, which provides herd immunity. So despite the increase in vaccinations, California had a measles outbreak. It occurred in December of 2014, and it was linked to Disneyland resort theme parks in California. Related cases were identified in 6 other states, Mexico, and Canada, and it resulted in a total of 147 cases among unvaccinated or persons who did not have a known documented status for vaccination. And as Corey mentioned, measles is very contagious. So as a result of the outbreak, the legislature enacted SB 277 in 2015, and it went into effect in January of 2016. It completely eliminated the personal belief exemption from immunization requirements, and beginning July of 2016, it requires schools and institutions to not admit pupils unless they are immunized. It does, however, provide for some exemptions to the immunization requirement. It grandfathered PBEs filed prior to January of 2016 until the next grade spans being birth through preschool, kindergarten through 6th grade, and 7th through 12th grade. Pupils with a medical exemption by a licensed physician also are exempt. And pupils in home-based private schools or independent study programs with no classroom-based instructions are also exempt. Now, SB 277 does not prohibit a pupil who qualifies for an IEP from accessing any special education and related services required by his or her IEP. Once SB 277 was enacted, there was an attempted referendum to repeal it. However, the advocates were unable to obtain enough signatures, so it failed. Nevertheless, shortly thereafter, there were 5 lawsuits that were filed claiming that SB 277 was unconstitutional. And the first of the 5 cases was Brown v. Smith, and it was filed in April of 2016 as Buck v. Smith in Los Angeles Superior Court. The Superior Court dismissed the case, and the plaintiffs appealed, but the Court of Appeals agreed with the lower court. The appellants in Brown v. Smith claimed that SB 277 violated the California Constitution based on free exercise of religion, the right to attend school, equal protection, and due process. The appellants also claimed that vaccines are medical experiments and that SB 277 violated a California law that provides that no one may be subjected to a medical experiment without his or her informed consent. As to freedom of religion, the court said that the state's wish to prevent the spread of communicable disease clearly constitutes a compelling interest. So even under strict scrutiny, the appellant's argument fails. The court said that mandatory vaccination as a condition of school admission does not unconstitutionally infringe the right to free exercise, and the court relied on Jacobson v. Massachusetts and its progeny. In regards to right to attend school, the court said that the right of education, fundamental as it may be, is no more sacred than any of the other fundamental rights that have given way to the state's interest in protecting the health and safety of its citizens. The plaintiffs argued that SB 277 discriminated based on vaccination status, and the court said that when it comes to preventing the spread of contagious diseases, children attending school are more liable to contagion. Therefore, this effort was for the benefit and protection of all people, and it in no way interferes with the right of the child to attend school. The plaintiffs claimed that SB 277 was void for vagueness. They claimed that the legislative goal and medical exemption language were vague. However, the court said that it had no difficulty in perceiving the legislative goal, which is not new. The goal of total immunization has been stated in statute since its passage, at least since 1995. It also said that the medical exemption on its face is sufficiently clear to give fair warning of the requirements. The second case that was filed was Whitlow v. California Department of Education, and that was filed in July of 2016 in federal court. The parents again claimed violation of due process, equal protection, free exercise of religion, and right of education under the California Constitution. They sought a preliminary injunction preventing the state from enforcing the law. However, the district court denied the motion and held that the parents were not likely to succeed on their claims, so the plaintiffs withdrew the lawsuit. The plaintiffs argued that SB 277 denied children with PBEs the opportunity to attend school and stigmatized them. But the court said that imposing a mandatory vaccine requirement on school children as a condition of enrollment does not violate due process, and an exemption is not required under law. The plaintiffs alleged that SB 277 treats children with PBEs differently in denying them an education, but the court said that children are not similarly situated, and even if they were, the plaintiffs failed to show that the children are members of the suspect class. Therefore, they would be subject to rational basis review and would meet the test because the government has not only a legitimate but also a compelling government purpose. So even under strict scrutiny, the law would pass muster. The plaintiffs claimed that the law, SB 277, failed to provide a religious exemption. Therefore, it violated their free exercise of religion. But the court said that the right to practice religion freely does not include liberty to expose the community to communicable disease, ill health, or death. And as far as the right to education, the court said that society has a compelling interest in fighting the spread of contagious diseases through mandatory vaccination of school-aged children. The court concluded that states can impose vaccination requirements without providing a religious or conscientious exemption. The third case that was filed was Middleton v. Pan, And this was filed in the U.S. District Court in July of 2016 on the same day that the Whitlow case was filed. However, this was in a different district court. The plaintiffs were parents and their children who were either unvaccinated or partially vaccinated. They represented themselves, and they claimed that the legislators, the governor, and their spouses violated the Racketeering, Influence, and Corrupt Organizations Act, known as RICO. However, in July of 2017, the district court dismissed the claims in the plaintiff's first amended complaint, and the plaintiffs then filed a second complaint. They added as defendants the counsel to the state defendants. They alleged RICO violations for introducing, sponsoring, voting for, and persuading others to vote for the signing of SB 277. And they alleged conspiracy to promote the sale and use of biological and chemical weapons. In December of 2017, the U.S. magistrate judge recommended that the second amended complaint be dismissed. The judge said that legislative activities are entitled to absolute immunity. The 11th Amendment bars suits for damages against the governor in his official capacity, and state government attorneys are immune from suit for conducting their official duties. In January of 2018, the district court accepted the recommendation of the U.S. magistrate judge and dismissed the case. The plaintiffs appealed, but they failed to file an opening brief, and the Court of Appeals dismissed the claim altogether. The fourth case was Tory Love v. California Department of Education, and this involved, as plaintiffs, parents and their under- and unimmunized children, as well as a nonprofit organization. They filed in federal court in November of 2016, and they sought an injunction claiming that SB 277 violated due process and equal protection. The court denied the motion and dismissed the case in January of 2017. So the same plaintiffs then filed a new case in California Superior Court in April of 2017. And the Superior Court decided in favor of the state, but the plaintiffs appealed. They claimed that SB 277 again violated due process, right to public education, exercise of religion, and they added a new claim, right to privacy. The Court of Appeal affirmed the Superior Court's decision in favor of the state defendants, however. As far as due process, the court cited Whitlow, one of our previous cases, and stated that the objective of total immunization is not served by a law that allows for exemptions, whether the exemption rate is 2% or 25%. And removing the exemption is an aggressive step, but an aggressive goal requires aggressive measures, and California opted for both. The court recognized, as in the Brown case, that when belief exemptions to vaccination guidelines are permitted, vaccination rates decrease and the community immunity wanes. The plaintiffs claimed that SB 277 violated their right to privacy. They argued that it required children to reveal personal medical information to attend a free public school, and that it required parents and children to forego control over the integrity of the children's body. But the court said that although the right to privacy is important, it's not absolute, and it must be balanced against other important interests and may be outweighed by supervening public concerns such as public health and safety. As far as the right to attend school, again, the court agreed with the Brown court. that enacting SB 277 was within the police powers of the state. And as far as the free exercise of religion, the court also agreed with the Brown Court. In summary, all of these cases relied on Jacobson v. Massachusetts and its progeny, which is still good law. Jacobson stated that liberty is not an absolute right. There are manifold restraints to which every person is necessarily subject for the common good. So just to take a look at the current status of immunization in California, as we can see, when SB 277 went into effect in 2016, there was an increase in all required immunizations and a decrease in PVE, which is the purple. However, we see a slight increase in medical exemptions, which is the orange. Comparing immunization rates of kindergartners pre and post SB 277, we see a lot more red counties versus in 2017-18, we see less counties in red. And the red indicates less than 90% immunization rate. Looking at the percentage of kindergartners with all immunizations, in 2014, when AB 2109 was implemented, we began to see an increase with the high in 2016 when SB 277 went into effect. And we see the same for the percentage of kindergartners who are immunized specifically with the MMR vaccine. We see less red counties. For specific vaccines, we see an increase between 2014 and 2016, again, with a high in 2016 when SB 277 was enacted. And we see that all of these vaccines are above the 95% threshold. Just like to acknowledge a colleague. And if you have any questions or seek resources, our website, shopsforschool.org, has resources, and also the immunization rates by county can be accessed as well as by particular school, and of course my email. So thank you. That concludes my presentation.
Okay, thank you so much to our presenters, Leila, Corey, and Nancy. That was incredible information, and I'm excited to now lead us through the Q&A portion. You'll see directions to submit your questions right here. So keep them coming. We've got some great ones, but we'd love to get some more. So I will just go ahead and ask the questions to all of our panelists, and then you guys can choose, which ones you want to answer. If there's one that perhaps is better geared towards one of you, I can kind of guide you to it. But for our first question, which let's give it to Leila, who is responsible for making vaccine policies at the university level?
Thanks, Chelsea. That's a great question. It really depends, but oftentimes it's like the Board of Regents or the university board that oversees the university. Here in Arizona, we have 3 public universities under an Arizona Board of Regents. And so oftentimes that is the type of group. The group that oversees the university is the one that might have the decision making. Sometimes it may be just at the university level. Within the university, there may be some policy creation, just not if it's like an independent or a private university that doesn't have an overarching board or commission. It could be something just within their own university that they create their own policies. So it depends, and I think that it lends itself to why we were so interested to look at the different university recommendations and requirements, because they are so different among the different universities.
Thank you so much. Now, Corey, I believe you might have mentioned these chickenpox parties. Can you speak to any steps that a health department can take to help curb these type of parties that seem to be sweeping social media?
Yes, great question. Not a real solid answer or solution on that. I think it just takes public education and really pushing out the messaging of what this disease can really do, especially when you look at what it can do to very young infants, neonates, children with leukemia, and your pregnant moms. I mean, really kind of going into more of the varicella syndrome, congenital varicella syndrome, I think, just messaging that out and really trying to change that mentality and that generational thought. I just think it's difficult because we have difficulty changing the entire anti-vax movement, but we got to keep on educating. And I know with tobacco use, they've used very graphic details to really message very, very effectively what that can do. And maybe we just need to, I don't know, I'd like to see more graphic, hardline consequences conveyed to these families who are not vaccinating.
Thank you so much. And similar to those lines, someone asked if there's any jurisdiction, this could be for any speaker, that requires unvaccinated persons to register with maybe like a local or state health department. Do you think that's something that's legally viable? Is anyone actually doing that? For any speaker who would like to speak to it.
In California, we don't require registration, but for school-age children, the immunization records in terms of numbers immunized and aggregate information is collected, so we know percentages in schools of those children who may be immunized and those who may be not. In the event of an outbreak, they may be temporarily excluded from the school.
Thank you. Another question that we have, maybe for Leela, can you speak to any comparison between laws for university students and laws for school-age children with regards to vaccine policies?
Sure. One main difference is usually, so the state laws for children entering kindergarten and those requirements are usually outlined in state law or so state statute or in regulation. Whereas the university policies are not. So it could be, as I mentioned, something that's just based at the university level. It could be something that's universal among multiple universities if they're within a group under a commission or a board. But a big difference is where the policy is really directed. The children's laws are directed by the state or are really outlined in state law in the statutes and regulations, but the universities are not. So that is really one big difference.
Thank you. And then now for schools that do allow different kinds of exemptions, do schools verify the validity and accuracy of vaccination information that's submitted by parents? The concern really is that parents might be fibbing the information if it's not being verified. So can anyone speak to kind of any verification process, if any? Maybe Corey, I think you'd probably be a good person for this one.
Yeah, good question. There is paperwork to be filled out for exemptions, and I know, and maybe Leela can speak more to some of the educational pilots that are going on in our state, but for the most part, I think it varies. In our county and in our state, there's not a school nurse in every single school. Sometimes that entity is the principal's assistant. You might get a health aide. You might have a regional approach for school nurse coverage in an area. So I can't I don't know what the accuracy is, but I do know that there are times that they are understaffed, and the easiest thing to do is to get an exemption and fill out that paperwork and call it good and worry about vaccination later. Sometimes that has occurred, and we were seeing that a little bit with our, after we did some more education with our schools after, between the varicella and measles outbreak.
Thank you so much, Corey. Now, Nancy, I think we have a great question for you. Is there any experience with local governments trying to address vaccination requirements with a local ordinance rather than relying on state law? Can you speak to anything like that?
State law currently oversees immunization and through law and regulation. So counties, due to preemption, would likely not be able to enact any specific laws that may contradict state law. So that's just a general question, general answer. I'm not sure of the specifics that you might want to know.
Okay, thank you. And then for any of our presenters, I think a big concern is how do we address, declining vaccine rates and these outbreaks, before the outbreaks happen? How can we be proactive about it? Any suggestions from anyone besides what you've all already said?
Sure, this is Leila, I'll jump in. I think obviously that's a really hard question, and I'll defer to Corey at the local level, but I think at looking at some of the legal strategies, I think making laws harder, the exemption laws harder, so we've seen that happen in different states, so it's harder to get an exemption, so more than we do see after that increase in vaccination rates. And I think it's a really tough question, and we're seeing outbreaks right now, and I think everyone in public health and public health law is trying their best to address and prepare for outbreaks and hope that we can use policies to prevent future outbreaks.
Chelsea, this is Corey.
Thank you.
If I could just
go
add.
ahead. Sorry.
Oh, no problem. Yeah, I think on a local level, when you're dealing with not a lot of funding, not a lot of resources, limited infrastructure at times, I think what has been a recent best practice for our health department is every time we do have an outbreak, whether it's vaccine preventable or not, capturing the costs that are associated with that can speak volumes. And I know that they talked about that during the Disneyland outbreak. There was some articles out of Forbes and a few other outlets that talked about the cost of outbreak. And I think that needs to definitely be more on the forefront. I think the most effective way to deal with this is to put it into policy, put it into law. But associated with cost is going to maybe speak some volumes to smaller communities that don't have a lot of money.
Great points. Thank you. Our next question is, are local health departments allowed to obtain vaccination rates or coverage from schools in their county? Maybe it varies by county, I'm not sure.
This is Leila.
Yeah, go ahead, Leila.
Usually it's reported to the local health departments or the state health departments. It depends on, the state and how their laws are written, but usually the exemption rates are reported to a higher health department, be it the local or the state health department. And Court, I don't know if your experience has differed in that.
No, and yeah, I definitely wanted you to speak to that a little bit first. Yes, we do, the schools are required to report at the state level what their rates are. And at the local level, like during outbreaks, we have good relationships with our schools to query them what their current status is, if it's in between that reporting time to the state. So we can do that, and we have some health educators that can assist our schools in getting us that data, and we did do that during our 2015 measles outbreak.
Thank you. Now for Nancy, questions about SB 277. Can you speak to whether public messaging affected any of the response that you saw to this bill?
Public messaging in regards to the enactment or the implementation?
I suppose either.
Well, you know, even before SB 277 was enacted, there was a lot of challenges and controversies, and once enacted, like I mentioned, there was an attempt for a referendum to repeal it, and then we had the litigation. So I don't know if there was so much public messaging more than media coverage. I think that on our website, shotsforschools.org, the department included all of the information prior to SB 277 going into effect, and helped to answer questions for school districts and the public. So I think that that helped to prepare folks in implementing SB 277 even prior to the actual effective date.
Thank you. Now we have another question on peer-to-peer interventions, if any of you have experience with those interventions or programs to help combat anti-vaccination messaging at a more community or personal level, or perhaps any suggestions on how to do so. All right, if not, then we'll just move along, maybe something to think about. Let's see. Someone did have an interesting question on whether insurance companies have done anything regarding, you know, decreased vaccination rates, similar to like a smoking premium. Has anyone seen anything like this? Or think it's a good idea?
I've never seen anything like this, but I like the comparison to the smoking premiums as a you know, kind of comparison purpose there. But no, I've never seen that done. It could be, I just haven't, something I've never come across.
Okay, we did have one clarification. Oh yeah, go ahead.
Oh, sorry. I've just noticed that there is a varying difference in some insurance companies on what, especially adult vaccinations, they will cover. But I do see that opening up a little bit more, where they are, you know, offering the free shingles vaccine or pneumonia Prevnar vaccine to adults, where it won't cost them anything, or a very low copay to get those vaccines.
Thank you. Now we have a question, again, on local health departments. What advice can you give to local health departments working to implement effective quarantine and mandatory vaccination orders due to an outbreak in a setting with resistance from the local community?
This is Corey. I think definitely having your state laws that talk about outbreaks, if they have those, and communicable disease orders, you can't fight that. And we saw that a little bit with our varicella outbreak, as you guys saw, you know, we had a parent that said they knew their rights. We threw out our Arizona revised statute right away, and I think we just have to rely on that authority, and the health officers really have to take that hard line. I think, too, our health officer is always in contact with our board of supervisors, our government structure. They're keeping everybody apprised of situations and what the strategy and goals are. And usually when you explain all that, especially to the elected officials that are going to help support you, if you explain all that to them, it makes better sense and they have your support. But you have the authority to definitely exclude people during an outbreak if your state or local laws have that, which Leila could probably talk a little bit more about.
Thanks, Corey. Yeah, I mean, that is really dependent on the state law. We do have that, as Corey mentioned, in Arizona, but it would depend on whether the state you're in, or whether the state, the local health department is located in, I should say, whether that has such a law that allows for exclusion during an outbreak. Many states do, but it would be something to look into as to whether, you know, a state had that, and then that would provide the authority, as Corey mentioned, to exclude unvaccinated children during an outbreak.
Thank you so much. We've got time for a couple more questions, so keep sending them in. One person wanted a clarification back on, you know, when you verify whether what parents are giving, you know, to the schools as they're, you know, related to their exemptions, if you can, you know, verify if it's, you know, true or not. Does anyone here see that happening occasionally? I mean, I suppose it could happen, but the requester really wants to know, is this a possibility? Can parents, like, pretend? Yeah. Nancy, maybe you can speak to this a little bit.
Well, in California, we have an immunization database where the providers actually input the data directly into the database. It's not 100% running yet because some of providers are not all on there, but the school nurses, they do verify the immunizations, and in the past we used to have a immunization card that the doctor's or physician's office would complete and record the immunizations, but now with electronic database, more and more providers are relying on that.
Thank you so much. That's really good to know. I don't see any more questions, so perhaps the panelists want to, you know, give any final thoughts, and then we'll conclude the webinar, if you have any.
Great. No, I just wanted to thank everyone for participating in this webinar. If you have any questions for me, Leila Barraza, please feel free to email me. And thank you for allowing me to participate in this webinar, and thank you for joining us.
All right, and thank you to Corey and Nancy as well for your incredible presentations. Charles, I will pass it back to you for some closing remarks, and thank you guys so much.
Thank you, Chelsea, and thank you everyone for your participation in today's webinar. And for our panelists for presenting, I learned a lot, and I know our attendees did as well. So just a few final notes. You will be receiving an email that will have a video playback of this webinar, as well as a link to our brief webinar survey. We really value your thoughts about today's webinar and what topics you would be interested in for future webinars. You will also be receiving an email from ASL and me with information on how to apply for CLE credits for this webinar, if applicable. And finally, if you enjoyed this event, be sure to check out next month's webinar, Tackling Tough Public Health Problems Through Cross-Sector Data Collaborations, where speakers will examine a cross-sector collaboration between public health, law enforcement, emergency medical services, and other groups to address the needs of high utilizers of behavioral health services. And you can learn more about that by visiting networkforphl.org/webinars. And that concludes today's event. Thank you all for attending and have a great rest of your day.